I just wanted to let people know that we had Dr. Gottlieb, who's head of the FDA, who was going to come last month, is rescheduled for May 7th, and the program is shifted a little bit. It won't be a formal controversies. It's actually going to be a dialogue. There'll be a small he'll give a small presentation, introductory remarks, and then there'll be a dialogue, Dr. Fuster one-on-one with Dr. Gottlieb. There'll be an opportunity for Q&A, and then a private luncheon with fellows with the head of the FDA. So I think that'll be very exciting. Today's controversy is actually a great opportunity to welcome back one of our former colleagues, Dr. Fishman, who's presently head of cardiology and chaired Goldring Professor of Medicine at NYU. The topic is actually one of growing interest, as he cited at his noontime conference, of growing interest to cardiologists, pediatricians, geneticists, and sports medicine people as well. The topic, because it's fairly diverse, is difficult to put together, and Josh Kiss has put together an actually excellent monograph. And without further ado, Josh is going to give a brief overview of today's controversy topic, which is inherited arrhythmias.
Hey, everyone. So we're going to be talking about inherited arrhythmias, and specifically in the context of sudden cardiac death, which accounts for about 250 to 300,000 deaths per year in the US, primarily resulting from ventricular arrhythmias and especially VF. In individuals over 35, sudden cardiac death is most commonly occurring in patients with coronary heart disease, with or without heart failure, whereas inherited cardiomyopathies and primary electrical disorders prevail in younger sudden cardiac death victims. Only about 10% of sudden cardiac death occurs in structurally normal hearts without evidence of coronary disease, cardiomyopathies, valvular disease, or congenital abnormalities. Inherited arrhythmias account for much of this and primarily include long QT syndrome, short QT syndrome, Brugada, and catecholaminergic polymorphic ventricular tachycardia. These disorders result from mutations in genes encoding cardiac ion channels, receptors, and associated regulatory proteins that modify the cardiac action potential or intracellular calcium handling, creating electrical instability and predisposition to life-threatening ventricular arrhythmias. As primary arrhythmia disorders occur in patients without structural heart disease, who are typically unaware of their disorder, sudden cardiac death may be the first presenting symptom, and early diagnosis is important. These disorders are almost all autosomal dominant disorders, but have incomplete penetrance and variable expressivity, which makes clinical diagnosis somewhat challenging. The addition of genetic testing may offer a definite diagnosis of particular electrical disorder, confirm or exclude a disease-causing mutation in family members, and allow for personalized treatment recommendations of a patient's specific disorder. Genetic testing has been progressively introduced in clinical practice and is currently advised in most inherited arrhythmias. There are significant limitations to the effectiveness of genetic screening, however, as there are negative results in about 20% of patients with long QT, 40% with CPVT, and 80% with short QT syndrome or Brugada. Ongoing work to improve management of these disorders involves further identification of genetic causes as well as clinical methods of risk stratification to determine appropriate therapies, including medications, lifestyle changes, and ICDs. Long QT is characterized by prolonged AP duration, either as a result of increased inward sodium or calcium currents or decreased outward potassium currents. The symptoms in long QT are characteristically triggered by different circumstances that emphasize the underlying electrical disorder. For example, long QT1, there's mutations in the IKS currents which respond to progressive adrenergic stimulation, such as during exercise. So these patients tend to have arrhythmias during activities like sports and other exercise. In long QT2, mutations affect the IKR currents, which play a role in abrupt increases in heart rate. And And this increases the risk of arrhythmia symptoms in patients during stress or emotional circumstances. And then in long QT3, you have mutations that affect the INA currents, which become more evident with slow heart rates. And so patients tend to have their arrhythmia events during sleep or other bradycardic events. Genetic testing is actually the best for this syndrome. You can have conclusive results in up to 80% of patients, especially with those 3 most common genetic findings. Short QT is very rare. You only have about 200 cases that have been reported in only like 50 families. And they manifest with a very short QT interval, which is a result of increase in repolarizing outward currents or a decrease in inward currents. And ventricular arrhythmias result from heterogeneous distribution of this abnormal conduction through cardiac tissue. These patients don't necessarily have a clear causative mutation most of the time. It's only found about 15% of patients. And so genetic testing is not as useful in these rare cases. Brugada is typically asymptomatic, but you can have ventricular arrhythmias in 17 to 42% of diagnosed individuals. And this can account for up to 20% of sudden cardiac death in patients who have no structural heart disease. They tend to present when they're young, in their 20s and 30s, most likely male, 8 to 10 times more likely to be male. It's characterized by the type 1 EKG, which is a coved type ST segment elevation in the right precordial leads at the 2nd, 3rd, or 4th intercostal space, and obviously a susceptibility to ventricular arrhythmias and ICD, or SCD, sorry. This results from an imbalance between inward and outward currents and early repolarization, either due to a decrease in inward sodium and calcium currents or an increase in outward potassium currents. The EKG findings can be spontaneous or provoked with sodium channel blockers. And the imbalanced currents create ventricular arrhythmias when premature repolarization affects some cells and not others, allowing for reentry. It's genetically heterogeneous, and only about 20 to 30% of diagnosed patients have a causal mutation, again, limiting genetic diagnosis. CVBT is very rare. It only occurs in about 1 in 10,000 people, and it manifests with a normal ECG at baseline, but patients are predisposed to adrenergic-induced bidirectional or polymorphic VT and sudden cardiac death. It's the only primary electrical disorder that doesn't directly impact the action potential in cardiac cells and results from abnormal release of calcium from the sarcoplasmic reticulum in response to adrenergic stimulation. This actually is generally from one of 2 mutations, either in the RYR2 or CASQ2 genes, and again, benefits from genetic testing. So the genetic tests have been progressively employed more and more in clinical scenarios, but due to genetic variability and heterogeneous expressivity, as I mentioned, it limits the test characteristics of these genetic tests, and again, is primarily utilized in long QT and CPVT, but less so in short QT and Brugada. ICD implantation is clearly the first-line treatment for sudden cardiac death in most patients with high risk. But up to 20% of these patients can have recurrent episodes of VT-VF or even electrical storm, which increases mortality acutely and leads to a significant decline in quality of life over the long term, particularly mental health as a result of frequent traumatic and painful ICD discharges. So this has brought up a lot of controversy in how to best risk stratify these patients and determine sort of who should get an ICD and who should not. The primary electrical arrhythmia syndromes are sort of a unique area in that they affect younger patients with structurally normal hearts and often strike catastrophically without warning. Despite years of research, we haven't necessarily identified a lot of the mechanisms in many cases for these patients. And so a lot of genetic studies are ongoing to try to identify the right genes to target, either for therapy or at least for screening for family purposes. Lifestyle changes and medications have helped to provide some patients improvement in their symptoms and risk of sudden cardiac death. And there's new things coming forward, such as ablation and some other options to help prevent some of this. But at the end of the day, it seems that ICDs still remain our best treatment, and it would be great if we could continue to work and find opportunities to find the right patient population for ICDs.
Okay, thank you very much, Josh. It's interesting how this field has evolved in the last 2 years. I had the opportunity to go to the articles published in JACC on the Brugada, the prolonged QT in the right ventricular dysplasia. There are 24 articles in 2 years related to this. And all, when you look at is the tremendous advances being made, how you put together the genetics, the acquired mechanisms, the trigger factors, and so forth. I think it's a fascinating type of topic to be addressed today. Well, I'm very pleased, actually. Glenn Fishman, frankly, is a very unique person. I know him very well. You know, he spent some time with us here. And let me go a little bit about his, let's say, biography. I will make it short, but he is a New Yorker, was born in Flushing, New York, and then he went to Cornell University College. Then he studied medicine. He obtained the MD degree at Stanford. And then he went to the Mass General in Boston, where he had his internship and residency in medicine. Then he came to New York, and he had the clinical fellowship of cardiology at Columbia. Then he has a postdoctoral fellow in molecular cardiology at Albert Einstein. And then he moved into Mount Sinai in 1998, where he was associate professor of medicine and director of the section of myocardial biology here at medical school. And well, eventually he ended up at NYU, and I wonder, you really know New York scenario better than anybody. Who do you think is the best? You were in all the institutions. He spent time in each of the institutions in New York. It's the first time I see somebody who has been in all of them. Well, anyway, at the present time, he's the director of Leon Charney Division of Cardiology and the William Goldenick Professor of Medicine, Vice Chair for Research Department of Medicine, Professorship of Physiology and Neurosciences, and he's Professor of Biochemistry and Molecular Pharmacology at New York University. They gave you so many jobs to say this is the best place in New York. Well, anyway, we have a very rich biography. He has been very, very much involved with the National Institute of Health, with the Heart Rhythm Society, with the American Heart Association. In the NIH, he has been a permanent member of the study section in cardiovascular, and in the general section, and in the program projects review as a member. So he's into it in all these grants that we submit. Now, in American Heart Association, he was the chair of the Heritage Affiliate Research Committee, but you're also the chair of the New York Heart Association. You know it's not in your curriculum. You should tell your secretary to add it. All right. So in the Heart Rhythm Society, Board of Trustees, Chair of the Basic Science Program Committee, and then President of the Cardiac Electrophysiology Society. So he had lots of jobs. Editorial positions, editorial board on circulation research, Journal of Molecular and Cellular Cardiology, editorial consultant of JACC in the Basic to Translational Science, and associate editor of Circulation, Arrhythmia and Electrophysiology. And then what is, I think this is most striking, I must say, is his mentorship. He mentored about 50 people, many of them actually with very important positions nationally, and some of them very recognizable internationally. So he's an academically driven individual where the number of grants that he obtained was significant, 17 NIH grants, 7 grants from the AHA. And then in Howard Hughes, he really was the mentor of a number of young people. And in terms of publications, he really has been very much involved and a pioneer in the field that is being discussed today. and that is in the issue of arrhythmias, particularly basic molecular mechanisms, in terms of the genetics, embryology, and so forth. He has about near 200 papers in very highly regarded journals about the issues. So, really a remarkable person, very humble, a good person, and actually we feel so, I was telling you, I feel so pleased and so proud actually that he's doing so well at New York University, and the job that he's doing is a wonderful, a great job that he had for many, many years. So thank you for coming, Glenn, again. I hope you saw some changes, positive changes in the institution, and let me give you something that you recognize from your times here. It's an honorarium. I'm not sure it's changed. It has been very flat, you know, and here is the plaque that we, the faculty and the fellows, offer you for, in the name of Anandi Sharma, which is the father of Samin Sharma and Simon Duck, today as memorial lecture. Congratulations. Thank you. We're lucky he's on time, otherwise I would be sure only with him.
He wasn't on time.
Yeah.
True to form. Just go a little bit, service the light.
Oh,
Thanks.
Good. Okay, so thank you very much, and let me give you the plaque, Glenn, and then let's call. I never knew there were so many experts in this field in the Mount Sinai. There are 1, 2, 3, 4, 5, 6, 7. All right, let's begin. Snivas, Dr. Kapati, Dr. Akar, Dr. Amy's here too, Barry Love, William Wong, and certainly Josh. Okay. I ask, we ask Vivek Reddy to actually be the person today to drive this very interesting subject.
okay. Thank you very much, Dr. Fuster. Let me just bring this up here. And I want to thank Dr. Fishman and the rest of the panel for joining us up here. It's a complicated subject. It's a subject with lots of data in some sense, not enough data in other sense. And this is inherited arrhythmias. What I'd like to do is to try to cover three broad subjects: Brugada syndrome, long QT syndrome, and a little bit of CPVT. So why don't we start off with Brugada syndrome? It turns out this is the 25th anniversary of the identification of Brugada syndrome by the Brugada brothers. And it's a syndrome that has various sort of clinical expressiveness. It ranges from complete lack of symptoms in about 2/3 of patients to presenting as even a sudden death in about 7% of patients. So you have the wide spectrum. In some sense, it's easy for us in terms of management when a patient survives cardiac arrest because, well, we'll talk about the various possibilities. But it certainly becomes much more complicated in the patients who have asymptomatic Brugada. Brugada syndrome is when it's present, it's relatively characteristic on the EKG, on the 12-lead ECG. And I think it's not an infrequent consultation to the electrophysiology service to look at the EKG and see what we think about this. So let me just say, there was a study that was performed that looked at the initial presentation of Brugada syndrome. And in 47% of the patients, they presented because of family history, followed by an incidental EKG finding in 25%. In fact, actual clinical symptoms like syncope and arrhythmia was really only present in a minority of patients, in just about 1/4 of patients. Syncope in 14%, arrhythmia in 13%. So the majority of patients that we deal with are really asymptomatic Brugada patients. So why don't we start there and start looking at how do we deal with these patients when we have someone with asymptomatic Brugada? And maybe, actually, just stepping back a little bit, why don't we talk a little bit about the mechanism of this? And so maybe I'll ask Dr. Fishman to start off. As many of you know, there are a number of different genetic factors that have been identified in Brugada syndrome, and there's no sort of single gene that's the problem. There are a few, but Dr. Fishman, you want to just comment on what the mechanism is in Brugada syndrome.
Right. So obviously, Brugada syndrome was originally described by its ECG findings, and then sorry, I'll say. Brugada syndrome was originally described by its ECG findings and its clinical presentation, but as genetic testing became more and more possible, we started making some linkages between genetic etiology and this clinical phenotype. And truthfully, most patients with Brugada syndrome, there still is not a clear genetic basis for it. Sodium channel mutations account for perhaps 15 or 20%, and a variety of other mutations are associated with Brugada syndrome and another 10 or 15%. All of these are thought to change the equilibrium and the balance of currents between inward currents, which are usually carried by either sodium or calcium, or outward currents, which are typically potassium. And so many of these genes affect that balance of currents and are thought to be causative here. The problem is we have about 80% of cases where there is no clear genetic etiology, and we have patients who have clear-cut mutations who have no presentation at all. Their EKGs are normal, and they don't have the Brugada syndrome clinically. And so it's somewhat of a quagmire making the connection between the genetics of this disease and the clinical presentation. In some ways, Brugada and these other channelopathies, we may think of these somewhat as oligogenetic diseases. There may be one mutation that's driving it, but there are others that you have to co-inherit to actually make you have a clinical presentation. And sometimes you'll get that from mom, sometimes from dad, sometimes from neither. And that's why you may find that somebody has a sodium channel mutation, and even though their dad had it and has the clinical scenario, that individual does not. So this makes these associations between the genetics and the clinical presentation incredibly challenging. Regardless of that, it's this imbalance of currents, which seems to be most prominent in the RV outflow tract, which is where we usually see the presentation and usually where the source of the arrhythmias are. Whether there is a structural component is sort of a hot area of debate still in the field, and whether alterations in these currents lead to some remodeling, some fibrosis, some loss of myocytes in the RVOT is also an area that's under investigation. I think one of the most somewhat rewarding but perplexing aspects still is that when you think of this genetic disease that's affecting essentially every cell in the body, including all the cardiac myocytes, the fact that ablation can be effective when it's targeted to the RVOT is really sort of a seminal discovery here. And I think when, actually at our place, when Larry Chinitz was first doing an ablation for a Brugada patient in the RVOT, it seemed nonsensical. It seemed totally irrational, and yet that has come to pass.
Yeah, I want to get more to that. Before we get there, let me ask Dr. Controversies, what is the role of genetic testing now in Brugada, if any? I mean, it is quite complex, lots of genes. How do we think of this?
Right, so as Glenn said, the genetics are varied and the penetrance is variable. So I think, as with any of these channelopathies, it's essential to have a discussion with the patient at the get-go about their expectations, because we can use a small panel or a large arrhythmia panel to test patients, but if there's not a clear phenotype, then the yield is going to be quite low. And I think 20% is even a high estimate. So if there's a Brugada pattern on the EKG but no symptoms, then I'll counsel patients that they should expect very little from the testing, and many patients will decide not to proceed. But if there's a phenotype there's an EKG pattern, there's symptoms, there's syncope, there's arrhythmia, then I would counsel them that the yield is higher. So, there's no one answer to this. It's a discussion you have with the patient.
So let's say it's a patient who presented with syncope, has a Brugada phenotype, in the EP lab is given procainamide, characteristic pattern, non-polymorphic VT. How do you think about screening that patient and that patient's first-degree relatives?
I think it's appropriate to take a stepwise approach, and that if that's the most affected individual in the family, then the panel testing for Brugada genes can be applied. And if there's a positive pathogenic variant that's identified, then the first-degree relatives should be screened one generation at a time. And even in the gene carriers in that family, there may be silent, asymptomatic individuals. There's debate about how those folks should be followed, but I would advocate for periodic assessments, EKG assessments.
What is periodic? These are always the tough questions.
Right. Yeah, again, this is subjective, but I
Yeah.
would say for young children who are interested in sports, I would say do an annual clinical assessment with EKG, but I would also defer to Barry on that. And then in adults who are maybe not pursuing competitive athletics, you could be more relaxed about it.
Yeah, I want to get to the competitive athletics. That's such an important thing, and it's an important issue for quality of life of patients. But before we get there, I want to come back to risk stratification of these asymptomatic patients. So now we have some patients, usually asymptomatic, but not always. And one question is how to risk stratify them. One area that's been pretty hotly debated in our field has been the role of program stimulation. Recently being how long? Yeah, 2 years ago, or a year and a half ago, there was a publication, a pooled analysis of a number of observational studies looking at patients with Brugada syndrome. And they looked at over 1,000 patients, 1,312 patients, and they were able to get patient-level data from 8 different studies and pool all these data. And these patients many of these had program stimulation. And what they found was that induction during electrophysiology study was associated with increased cardiac events during follow-up with a hazard ratio of 2.66. So program stimulation did have a role, but importantly, the role was really most pronounced when you look at induction with either single or double extrastimuli, meaning without a terribly aggressive protocol. If you do triple extrastimuli, rapid pacing, then there was a higher incidence of clinically insignificant induction. So that was one interesting development. Of course, the other is the clinical development, or the clinical observations that Brugada patients who certainly present for a secondary prevention that has already survived a cardiac event are at higher risk. So the patients, again, the asymptomatic patients, how do you look at, so Barry, let me ask you, how do you look at patients who have, let's say, spontaneous, you want to talk about the role of spontaneous EKG pattern versus induced pattern in terms of trying to risk stratify these otherwise asymptomatic Brugada patients?
So I find it really hard, and I struggle with this. One of the problems that we have is that, when you're dealing with really young patients, it's really tough because in an older patient, you explain it to them, and an older teenager and an adult, if you think that they're at higher risk for sudden death, you can put an ICD and you can sort of fall back on that. But what do I do when I've got a 5-year-old or a 3-year-old? I've got a 5-year-old right now who's got a spontaneous Brugada pattern almost all the time, who I thought was at higher risk, but I don't know what to do with him. He's never had an event. I actually ended up putting a link monitor in him with the idea that, well, if I saw asymptomatic arrhythmia, that maybe, at that age, we could put in an ICD. So if I saw asymptomatic arrhythmia in him, maybe I'd be more prompted to do that. He's had that for about a year now and has not had anything, but he walks around with a type 1 pattern all the time. And I'm worried about him, but I don't really know what to do with him. Again, with that data, even with, when you're saying their hazard ratio may be twice as high to have an event, it's still not that high in any one patient. And so the problem is that if you start to do other things mechanically, like ICD or something, you're certainly gonna wind up with mechanical complications from a device in a child of that size. So we really struggle in pediatrics with this question. We have other patients that present, for instance, it's not that common, but a not uncommon presentation. They show up in the ER with fever, and somebody gets an ECG for some reason, and they've got a Brugada pattern, but only with fever. That's a little bit easier for me, especially if they're young kids, especially if they're girls, because you can tell them that really the chance of them having something bad, especially if they're a girl, especially if they're young, is pretty small. So we aggressively manage fever from that standpoint, and kind of leave it, and probably leave it at that and follow them up. But again, I don't really know what we're doing. Seems like the risk is fairly low, but I don't know what. And then Amy had brought up the sports participation. It's not clear that in Brugada that sports is such a terrible risk for these patients. So I don't know that I would counsel competitive athletics. I don't have that many patients that are of that age where I've had to deal with that problem, but it certainly is a vexing question.
It's interesting. There was actually a recent publication in JACC that looked at ICDs in children and adolescents with Brugada syndrome. And it was a massive study with almost 35 patients. So Brugada syndrome, as you know, is obviously very infrequent, and finding Brugada in children becomes even more difficult. But it was a very interesting study. It's actually the largest of its kind, 35 patients. The mean age of the ICD implantation in this population was 13 years. So, and with a range of 6.2 years. So some very young patients also got the device. And the majority of these patients were symptomatic. Asymptomatic kids don't get devices, and as Barry said. And of these patients who received the device, almost a third of them presented with an aborted cardiac arrest, and the remaining presented with syncope. That was their initial index event. And in a follow-up of about 88 months, what is that? I guess that's whatever that is, almost 5 years, sustained arrhythmias were seen in a quarter of the patients, including shocks in a quarter. And of course, remember that whatever you see on defibrillators is an overestimate of what actually would have happened, because some of these episodes would probably have terminated if patients did not have a defibrillator. But it's still not infrequent, but then you balance that against the 20% of patients who experienced inappropriate shock and the 14% that had device-related complications. So we're talking about significant potential for complications too. Just to put some numbers, a Brugada patient who presents with VF or syncope, who's resuscitated, actually, who presents after a VTVF episode, their risk is close to 10% in terms of recurrent VF or ICD shock. It's about 2% if the initial incident was syncope. It becomes around 1% when you have asymptomatic Brugada patients who present with a spontaneous EKG, Brugada pattern. And it's less than 0.5% with the asymptomatic patient who has no spontaneous pattern. So the pattern is only induced, diagnosis is only made with provocative agents, adrenaline or procainamide. Now, there was an interesting article I came across. It was written by Sami Viskin, and his article was entitled, it was in the circulation, actually it's still in press, I guess. It's called Radiofrequency Ablation of Asymptomatic Brugada Syndrome. Don't Go Burning My Heart. Nice title. He wrote this article because in Britain, there was, a couple years ago, there was a very, what's the right word? There was a very unfortunate incident that happened. There was a patient who was, or individual who was young, who was, had a low risk, had Brugada, but no spontaneous pattern. And then he passed away. So there was an online petition that basically said, and I'll just read part of this to you. My partner was diagnosed with Brugada in July 2015, had numerous tests, and was classified as low risk. He begged to be fitted with an ICD, and each time was told he didn't need one. He had no risk of heart attacks in his family. That's not what they meant. But anyway, he died in August 2016. Losing my partner has destroyed me and our son. So this started a big online petition. Over 100,000 people have signed up online to try to get the government to basically allow ICDs in everyone, in every Brugada patient, that is. I bring this up more because this has led, obviously the government's not going to allow that, but this has led to this idea of maybe instead of putting an ICD, which does have risk, to start doing ablation in patients. And so I want to use this as a segue to ablation. A couple of years ago, Natamani published an article that was very surprising for most of us in the EP community, where he basically showed two things. One, he went into the epicardial space in patients with Brugada, and he showed that there were abnormalities, structural abnormalities that you could see. The electrograms were characteristically abnormal over the right ventricular outflow tract. That was the first observation. And the second observation is that when he did ablation at those locations, and initially had like 9 patients or something, that those patients who had high incidence of ICD shocks or Brugada suddenly showed no ICD shocks. He also showed normalization of the Brugada pattern on the EKG. Now, since then, there are not too many patients, but since then, Carlo Paponi in Milan, I think still in Milan, anyway, somewhere in Italy, and Joseph Brugada have teamed up, and they've done a lot of ablation on Brugada patients. And they had a recent publication in about a year ago in Circa Arrhythmia, where they looked at 135 Brugada patients, so a lot of Brugada patients. And they did EP studies and catheter ablation, epicardial ablation on all these patients. And they basically have extended an initial observation and basically have shown that ablation seems to normalize the EKG in all these patients, that ablation leads to subsequent low event rate in terms of recurrent ICD shocks. And of the 135 patients, at a mean follow-up of 10 months, only 2 patients underwent repeat procedures, and that was not for symptoms. I'm sorry, those were for recurrent symptoms, so recurrent arrhythmias. So with that sort of observation, that group has now gone on to do ablation even in sort of earlier stage. They have a publication in JACC, which I want to refer to, that just came out, I think, this month, this week, there it is, just came out. And maybe I'll ask Srini about it because he knows when it was actually published. But just very briefly, they had almost 200 patients. About half of them were symptomatic patients, about half of them were asymptomatic patients, so high risk and low risk. And they did detailed epicardial mapping in all these patients as well as induction. And Srini, do you want to talk more about this?
You have the paper probably in front of you.
I do, which is easier for me. Well, let me just say 1 or 2 things, then I will ask you to talk about this and tell us how you interpret this. What they basically found was with stimulation, yes, there was a slightly higher percent of the symptomatic patients that were inducible, but it was a high percent of asymptomatic patients who were also inducible. And the other thing that they found was that the single most important predictor as to whether or not these patients would have had clinical arrhythmias was actually the size of the substrate on the epicardial surface. So the question from this is, what does this mean, Srini? Should we start mapping everyone with Brugada syndrome? Is this how we risk stratify patients in the future?
I think it's a little hard to take a step at this point. You pointed out a lot of...
Sorry.
It's a little hard to take that large step at this point. I think you pointed out a lot of the patients in that study were asymptomatic. And
half of them were.
Yeah, well, and
a lot were.
Yeah, so asymptomatic, really low event rates, and there's no clear indication to do anything in these patients, not only program stimulation. So the study you mentioned not only showed, basically it showed reduction of inducibility. They gave agmeline to all these patients who were asymptomatic. They induced, from what I recall, ventricular fibrillation or polymorphic VT in all of them after agmeline. They did substrate modification in the right ventricular outflow tract, epicardial, and then they repeated inducibility, and they kept ablating patients until they were non-inducible. And ultimately, everyone ended up non-inducible. That's a pretty hard thing to justify in someone who's asymptomatic. I think the event rates are really low.
Yeah.
What we see now, the event rates we see with Brugada syndrome now are much less than what were initially reported, which are the very symptomatic patients. So I think the event rates we see now are very low, and particularly asymptomatic patients, it's extremely low. So I would not recommend doing this in asymptomatic patients. Certainly if they had symptomatic patients who have had ICD therapies, I think this is the next frontier. And if you look at the paper, it's actually very interesting when you do these EP studies in these patients. They have clear examples of where VF or polymorphic VT occurs with 1 extra stimuli, which is actually quite surprising. And so I think those patients may be at risk. The role in asymptomatic patients is unclear at this point, whether we should do anything. But I think in symptomatic patients who've had ICD shocks, I think it's something to entertain.
So, Josh, I mean, as you've read this literature, you've probably been struck by the lack of randomized data, right? There's no real control data here. I shouldn't say control, randomized data because of the small numbers of patients. And this is the problem when you have situations like this where there's so few patients to actually study. What Srini says is right. We're not going to ever, it's hard to justify doing catheter ablation or even just EP studies, epicardial mapping studies in asymptomatic patients, but we're also not going to ever have randomized data. I think it's very unlikely. So we have 4 therapies in the asymptomatic patient. No therapy, of course. We just watch these patients because they're low risk. Quinidine therapy. This is, quinidine has a ITO blocking effect, which does seem to at least normalize some of the changes. But quinidine is not the easiest drug to take. ICD implantation and RF ablation. So you're practicing right now, and you see these. When you see these, if you see a patient like this, what are the things based on your read of the literature that you're going to think about to try to decide which of these options to employ in a given patient?
Yeah, I mean, I think it's a tough question. A lot of what I saw was really trying to figure out how to risk stratify these patients and figure out what the the best modality is. I mean, I think clearly if somebody has some sort of significant symptomatology or has had an aborted cardiac death, the answer is clear, they get an ICD. When you have these patients who haven't presented like that, I think it becomes a lot more challenging. And so, what I found was that, there's certain clinical factors that you can look at. So if somebody has we talked about this a little bit, but if somebody has a spontaneous type 1 EKG, that's somebody that you might look a little bit more closely at in terms of their risk. If somebody has a lot of QRS fragmentation on the EKG, that would be somebody else who maybe is a little bit more at risk. So there's some, sort of ECG findings, clinical factors that you can look at even if they haven't presented with symptoms. So I think those would be people that I would look a little bit more closely at in terms of more aggressive treatment. I think, I may be wrong, but I think sort of what I found is that the medical treatment, for the most part, is not all that effective, and it's really sort of more for people who have continuing symptoms even though they have an ICD in place. They've had a lot of shocks, and that's when you start to think about medical therapy. So I don't know that I would necessarily go to medical therapy off the bat. I think it would be sort of somebody who seems to have less risk, maybe a little bit more watchful waiting. Somebody who is more likely to, based on their various clinical factors, I might start to think a little bit more about maybe going down the PES route or something like that to try to identify something a little bit more aggressively.
Dr. Fisher, what do you think about the role of implantable loop recorders in this population? I mean, ILRs have become increasingly easy to use. Barry just talked about his one patient that he put it in. Of course, none of us want to see a VF event on an ILR recording.
Right.
But
So, I mean, this is sort of the classic lose-lose situation in medicine, right? Where these are low-risk events, low probability events, but devastating events. And so we want to go out of our way to prevent these unfortunate occurrences, but we have very little guidance about how to do that. Before I get back to the loop recorders, I was going to mention the technique of ECGI, right? Which is
sure.
An emerging functional imaging technique to look at activation and recovery, activation and repolarization of the heart. And it's a very functional measure. And I think it may emerge as an intermediate step. Requires a scan, either a CT scan or an MRI, so it's not like coming in for a blood test. But it's not an invasive test, like going in for an EP study. It may help, and I think there's some preliminary data from the WashU group and others. It may help discriminate between those who have relatively normal degree of heterogeneity in the RV, RVOT, and those where it's exacerbated, and move somebody in the intermediate risk group and move them into a higher risk group where you might be more aggressive. And I think those are the type of developments we need to deal with that very difficult population.
especially Brugada, it is epicardial. Most of
So
at least the disease seems to be. That could be useful for us. Before I move away from Brugada to long QT, Fadi, can I ask you, there is data that suggests that indicates that certain drugs are not good for patients with Brugada, just as in long QT, and I really want to talk to you about that. What data, or what studies have been done, what basic studies to help us understand the interaction between medications and Brugada
I think that's
phenotype?
where some of the disconnect between the basic science laboratory and the clinical EP laboratory still exists, surprisingly, in this field. So the way to address this is, and Glenn touched upon this, is that we believe that the mechanism for the Brugada syndrome, for VF and the Brugada syndrome, has to do with this imbalance in ion currents that occurs in the early phase of the action potential, and that between the inward and outward currents. So knowing that seems to be the prevailing reason for the initiation of these arrhythmias, we can go back and try to improve the unmasking strategies using pharmacology to see which agents can unmask the phenotype experimentally. And that's why that ajmaline and others came about. But we can improve our sensitivity rather than go with empirical strategies like program stimulation, things that you do in a heart failure patients to try to go about doing it in inherited arrhythmias with low, yield. I think there's a lot of a space in trying to improve our ability to unmask the phenotype.
Before moving on to long QT, let me just open up the floor if there are any questions, or we can save them till the end. But if there are any questions right now, Dr. Fuster.
I have a question. There are two streams. We already know no symptoms or symptoms, and you know what to do with the symptoms. No symptoms is the debate. My question is, if I recall, when all these patients are stimulated and they develop arrhythmias, you mentioned the substrate, and I captured that the amount of substrate was important, but was very few people with that substrate who develop arrhythmias. Is this correct?
That is correct, and therein lies the problem. We're talking about mapping a lot of patients to identify a very small number. The flip side being that small number has a high risk of...
But it was very small number.
Yep.
In other words, the gain is not significant.
Right. Absolutely.
Well, also, I mean, with all the ablation and such, there's absolutely, very limited data to show it affects any outcome, such as decreasing sudden death.
In the asymptomatic
normalizes
patients.
the EKG.
Right, in the asymptomatic patients. In the asymptomatic patients, right. But again, I do want to, just to defend the authors, it's hard to do that study, right? I mean,
sure.
When you have an asymptomatic patient with low event rates, even if they randomize the patients, they had a good number, 100 patients. Let's say they ablated half and didn't ablate the other half. It's still, that you're never going to get the numbers to actually prove one thing or the other. So it is a problem.
The endpoint used is also inducibility, which is also not completely set thing for everybody. That's a controversial topic.
You must have reviewed there first. Right, I'm just kidding. Okay, so let's move on to long QT syndrome. So long QT syndrome is something that many of us have dealt with. We deal with it every time we look at an EKG. We check to see whether or not the QT is long. The classic symptomatology the patients present with is sort of the multiple syncopal episodes, and then the EKG is seen in long QT. About 13% of patients present with a cardiac arrest in these as their initial event. Now, there are multiple long QT phenotypes, or genotypes, I should say, and phenotypes. But maybe we could just go through, Dr. Fishman, you want to just go through the long QT 1, 2, and 3 and just sort of broad strokes?
So these were among the first inherited arrhythmias for which genes were identified, I guess from the Keating group. I don't know how many years ago it is, too many.
20 plus,
if I think
right?
back. Long QT3, I'm not taking them in order, but long QT3 is a gain in function, meaning that sodium channels, which normally let sodium into the cell, essentially they're open too much, and so too much sodium comes in. That's a depolarizing current, and so that spreads out the action potential, and that's manifest on the surface EKG as long QT. Long QT1, KVL is KVL-QT1, and long QT2 is the hERG channel. Both of those are potassium currents, and sort of conversely to the sodium channel mutation, these are loss of function mutations. And so there's too little repolarizing current. It takes longer for the myocyte to repolarize, the heart to repolarize, and again, you get a long QT syndrome. hERG is also interesting to point out because that's the major channel that's affected by drugs that cause acquired long QT syndrome. So it's a kind of a big channel, and it's sort of sticky. So a lot of drugs that we use for other purposes, this is sort of the off-target effect, and it's why a lot of drugs that are perfectly effective for their intended purposes have been either come with black box warnings or get pulled off the market because of increasing acquired long QT syndrome and sudden cardiac death. In this instance, most of the long QT are due to 1, 2, or 3, but there's a dozen or more other genes that contribute 1% or a couple percent to the total burden of long QT syndrome. And in that instance, genetic testing often returns the causative gene, and that is very helpful for sort of the cascade screening so that you can get information about the rest of family members and let them know if they are at risk, or you don't have to worry about that and don't have to serial follow them at all.
So when you have a patient with long QT, and again, in some sense, we have similar issues. We need to think about what kind of disease they have, and actually let's start with that. Amy, in terms of the three different, how important is it to do genetic testing? And can you talk a little bit about using genetic testing to sort of guide therapy from the perspective of both, things to avoid as well as medications, et cetera?
So this is the topic that genetic cardiologists get the most excited about, I think, because it's a relatively common cardiovascular genetic disorder compared to the other heritable cardiovascular disorders that we treat. And of those, it also has clear genotype-phenotype associations, both for the typing, long QT 1, 2, and 3, that Dr. Fishman just went over, but also within a given long QT syndrome type, there are specific mutations that are considered more malignant than others, either mapping to a particular protein domain or either loss of function versus gain of function, depending on which mutation we're dealing with. And so having the genotype information is incredibly informative. It can also be useful for activity recommendations for patients. So if you know the type, you can make specific recommendations. Can they go swimming or not? So in long QT1, which is associated more strongly with events during competitive sports or rigorous activity and swimming, if that's the genotype that's uncovered through the testing, my counseling would be for those patients to avoid swimming and to avoid competitive sports and rigorous athletics. Same goes for long QT2. These are patients where you would counsel them to avoid loud stimulation, loud noises, take the alarm clocks out of the room. A parent of a young child with long QT2 is advised not to yell at them to wake up, to gently wake them up. And then for long QT, and then emotional stress as well as an issue. And for long QT3, those are patients who are more likely to die in their sleep. And maybe those are folks who you might be more inclined to be aggressive with the ICDs. One more point about therapy, and I think you might get into this, but with beta blockers versus something like cardiac sympathetic denervation, having the genotype can also be useful for deciding the roadmap for therapy. And beta blockers should be first-line therapy, either nadolol or propranolol for long QT type 1. So I think it's very useful.
Yeah, and I just want to underscore that. I mean, the data is reasonable that propranolol or nadolol should be used, not metoprolol or some of the other drugs. You mentioned, Amy, the issue about athletics, and I just want to turn to Barry because you see a lot of kids, and this is an important issue. Of course, this goes beyond, of course, long QT. It really is sort of applicable to all these situations, these genetic conditions. And some of the early guidelines suggested that these individuals should not be allowed to participate in competitive sports. But then some of the more recent guidelines, the 2015 AHA-ACC statement indicated, well, that may have been too draconian a recommendation. There should be a shared decision-making interaction with the patients, the families, parents, et cetera. So how do you think about this in terms of when you have a 16, 17-year-old patient who wants to perform or wants to compete, what do you think about? What's your general sort of approach with these patients?
Right. So generally, I start by trying to figure out what I think their risk of an event is. So it's clearly somebody who's had, let's say, multiple events, who has an ICD, even if they're on maximal therapy and these sorts of things, you're going to be less inclined to potentially okay them for sports. You end up with a problem where somebody comes in and maybe there was a family history and they got genetic testing and they've got only a slightly prolonged QT, and you find that they've got long QT type 1 and they've got a QTC of 450 and they're on the basketball team, and then what do you do with that patient? So prior to the most recent guidelines, it was very frustrating because you really were put in a tough bind. And one of the toughest problems that I had was that Mike Ackerman at Mayo was taking all these patients and doing stress tests and then saying, well, I think we can okay this person for sports participation if they have an ICD and they have all these patients at the Mayo and hardly anything bad has happened to any of them. It's like, okay, Mike, except that you were on the writing guidelines that said that those patients shouldn't participate in sport. So it was a little bit frustrating. So now that these guidelines are out with the shared decision making, I think it makes it a little bit easier for the rest of us to at least be doing this. A lot of this, to be perfectly honest, is the patient or the sports team wanting my medical malpractice insurance to be their life insurance policy. Obviously, if I thought that they were high risk from sports, we would tell them not. But if we tell them that the risk is, elevated above the baseline, but it's still not very high, what do you do? What do you do with that information? So I think it's become easier now with the whole shared decision making. Having said that, you know, the teams and these sorts of things aren't necessarily buying into that. The schools may not be buying into that quite as much. But again, with the fact now that ICDs are so prevalent and, you know, required in schools and required, it's a lot easier to say, yes, they'll have an ICD at the events and they'll have an ICD at practices. And I think it becomes a little bit, it's become a lot easier anyways for us to potentially do this, you know, making sure, for instance, that a type 1 patient who doesn't have such a long QT is on beta blockers and they understand what the risk is, that it's higher than the baseline, but it's not super high, and that there's ICDs at the events. And during practices, I think, is a reasonable approach. I'll leave there.
Yeah, and then there's things like, of course, like counseling patients in terms of not taking other over-the-counter medications that interact, et cetera. You know, you mentioned Mike Ackerman, Mayo Clinic, and actually they published a paper recently you may be aware of. It was in a circulation. I think it may still be in press also. So they looked at their series of patients at the Mayo Clinic Genetic Heart Rhythm Clinic from 2000 to 2015. So these are individuals, these are athletes who were diagnosed with long QT syndrome. I'm sorry, not just long QT, multiple genetic arrhythmiopathies, let's call them. They had a total of 366 athletes, and about half of them, just a little over half of them were male. And after their shared decision-making interaction with these people, it turns out about 12% decided to self-disqualify themselves based on the interaction. The remaining did continue to compete in competitive sports. And what they found was that 9 of the remaining 322 athletes, that's 3%, experienced a non-lethal breakthrough cardiac event, of which half of those were outside of a competitive sport, that were just in their routine life. So patients actually seem to do quite well. I mean, 3% of a non-lethal event is actually, I would argue, is pretty good. So I think it certainly is consistent with what you're saying, Barry, in terms of allowing patients to not be completely controlled in terms of what they enjoy. Okay, now, unlike Brugada syndrome, where basically we're talking about do nothing, put an ICD, maybe an ablation procedure, with long QT, we have other options. We have, again, do nothing. We have beta blockers. We have sympathetic denervation. This is the stellate ganglionectomy. And of course, we have the defibrillator. So with this, and again, as Amy pointed out, in terms of beta blockers, really, we're talking about propranolol or nadolol, which have been shown to be effective. Cardiac sympathetic denervation, I think my guess is probably less frequently performed than it probably should be performed. Glenn, can you comment on that? You know, it's something that the Mayo Group has been talking about quite extensively. We've used it in a few patients, but I can't say that we've used it that extensively.
Yeah, I'm sorry. It's not used extensively at our institution either.
Yeah.
I think part of it is that the whole study of autonomic control of heart function is an emerging field, and so the sort of fundamental physiological basis for why this might work is not entirely clear yet. And so I think EPs, and you can speak to this better than I can, are a little more loath to adopt it without understanding exactly how it's going to be having its effect. And I think people then tend to move from, you know, prophylactic beta blockers to more aggressive putting in a defibrillator if they really feel somebody's at high risk. There are other institutions, I think, Silver Piori's group and others are using it maybe more in Europe than we are in the States. So it's quite variable among different institutions, though.
Yeah, no, I think that's true. Srini, any thoughts on this?
No, I was just going to comment about the.
Sorry.
I was just going to comment about the beta blockers and long QT. And the same issue with the Brugada and non-inducibility is a long QT syndrome paper from Silvia Priori this week.
Right.
And actually, nadolol is shown to be the best beta blocker, even compared to propranolol. And even in long QT3 patients, it's been shown to be effective. And so that's just something that's...
Yeah, Srini's referring to a paper, again, I think in press in JACC. They looked at patients, almost 2,000 patients. It's 1,710 patients with long QT syndrome, and followed these patients out for quite some time, almost, let's say, a median of 7 years. And they noted that nadolol was the best, and its beta blockers are useful not just in long QT 1 and 2, but also long QT 1, 2, and 3, which is a lot easier to remember that it works in all of them. So before moving on, Fadi, can we talk a little bit, Amy talked a little bit about gene-specific sort of management and how knowing which which long QT syndrome one has may help you determine how you treat the patient, how you counsel them in terms of avoidance of activities, et cetera. And I really like the fact that long QT too means that you could counsel people that they shouldn't be yelled at. Maybe I can try that at home. But I wonder, is there reasonable data, is there any data on utility of genetic testing to look at drug interactions with long QT?
Yeah, definitely.
And where do you, and the second part of that question is, where do you see that in terms of utility in clinical practice?
So yeah, I mean, again, understanding, the genetic basis and the specific mutation that's causing, that's causative of the disease will help, understand, what drug interactions can promote arrhythmias. And this is particularly challenging for the LQT2, considering that, as you mentioned, that HERG is such a promiscuous channel where so many of the, anti-inflammatory drugs or things that, take commonly will, interact with the channel to, bring out the first presentation being sudden death. And this is also very challenging, I think, for not just the genotype positive patients, but not the patients that have the phenotype positive, genotype positive, phenotype positive patients, but rather for the genotype positive but phenotype negative patients, those that don't have necessarily a very long QT, but do harbor that mutation, which can be really unmasked by common drugs. That's, I think, where the challenge of understanding the importance of matching genotype with phenotype, in these families. Yeah.
As I want to go from, actually, I'm sorry, before we head away from long QT, I have one last question. Josh, so as you were reading through and preparing your monograph, what, in terms of management of long QT syndrome, was there anything that struck you that you thought was somewhat unexpected, that you thought we don't do as routinely in clinical practice?
Yeah, so one of the things that came up actually that I was going to ask the clinical electrophysiologist on the panel was pacing, actually. So, one of the things that I found that I didn't sort of think about for long QT was pacing. It makes sense to at least sort of inherently speed up the heart rate. You're going to bring down the QTC and reduce the risk of R on T or something like that. But particularly for long QT3, bradycardia increases the risk. You think about pacing there. That was one thing that came up for me. You just sort of out of curiosity, is that something you would do? And obviously, I think to put in a pacer without putting in an ICD wouldn't make a whole lot of sense. So these would be patients that you'd probably put an ICD in, but would you use the pacing function?
Yeah, it's a good question. It's not that straightforward, right? Because you're talking now about putting in a dual chamber device, right?
Sure.
So which doubles the number of leads. Usually these are young patients. We're talking about having leads for a very long time, their whole lives. So it's not a trivial thing to say, oh, just let's put in a second lead. I mean, trivial technically, but not in terms of impact on the patient. I have to confess, I have not been very impressed with that. I think that there are patients, and perhaps if we knew that it was a long QT3 patient, that may affect us a little bit. But usually we think about that, or I think about that, in a patient who may have repetitive shocks, we may think about upgrading.
Sure.
Glenn, what are your thoughts on this?
Yeah, I don't think there's much experience at our institution with pacing at all in this scenario. So.
Yeah, I don't.
So if I can just jump in, so we use it in pediatrics and infants actually.
Infants,
not
that makes sense.
I mean, not infrequently. So for instance, just a couple weeks ago, we had a baby born with 2-to-1 heart block from a very prolonged QT interval, and that baby actually hadn't had torsade, but we put a pacemaker in on day of life number 1, and we're able to shorten the QTC. And I've had a number of infants where they present with long QT and torsade, and just by pacing them, you're able to shorten the QT and leave them less time to have early after depolarizations. And actually, it's been quite effective in a number of those patients. So again, where there's just no way to put an ICD in a little baby like that, and it actually works pretty well.
Yeah.
So just in that line, so Rocky Cass at Columbia had a paper a couple of years ago So this is, lung QT is one of those cases where actually making iPS cells and putting the mutation in and using that as an approach to test different drugs and seeing which are most effective, actually, there's some rational basis for that. In fact, they had, I think, a child who had very difficult to control lung QT, made these cells and tested a series of drugs to sort of understand which was most effective, and then we're able to bring that back to the child. And so in some of these difficult pediatric cases, it's potentially an approach.
How about, can I ask you about the mixilotine?
Yeah.
Any role of that? And
Yeah, so for the sodium channel mutations where the channel's open too much, sodium channel blockers are a rational approach, and mixillotine's been used for some of those. So some of the problems with long QT mutations is not that the channel just either opens or closes too much or too little, but sometimes it's the trafficking. And with some of these therapies, you can make the channel open or close more, but also move it to the membrane more or less. And sometimes you're fixing one problem but creating a second problem at the same time. And that's why some of the IPS testing can be useful, because you can actually, in a real cell, see the balance of that and see what's happening to the action potential and make some predictions about what's going to happen to the QT interval.
in Severe Priori published that in long QT3 syndrome patients, in some of them were pediatric patients, mixilotine decreased subsequent arrhythmia events dramatically.
Right.
Yeah. Let's move on to CPVT, catecholaminergic polymorphic ventricular tachycardia. We don't see it that often, but we do see it, and it's a condition that is characterized. I mean, the classic sort of the question you'll see on the boards are going to be a patient who, usually a young patient, you put them on a treadmill and suddenly they show this PVCs of altering morphology or bidirectional VT. It's very classic and it's highly insensitive. You rarely see that. I mean, usually when you put these patients on a treadmill, you start seeing PVCs, but not this sort of bidirectional type of VT. But it's an interesting disease process. Let's just talk, Fadi, from a molecular perspective. The way I think about it is it's about calcium overload. Is that fairly simplistic, too simplistic? How would,
right,
what would you
no,
say?
that's exactly right. So the two, classes that are, or genes that are implicated in CPVT are the ryanodine receptor, which is the calcium release channel from the sarcoplasmic reticulum, and calsequestrin, which is the buffer in the SR that holds calcium. So mutations in either of those will ultimately cause abnormal amount of calcium to flow from the SR to the cytosol. And that can trigger a series of events that can cause these triggered arrhythmias to occur. That's right.
So, Glenn, in terms of, we'll jump forward to treatment really quickly. Beta block is certainly one of the primary things that we use in these patients. Also, a sodium blocker like flecainide. So what's the mechanism of, can you explain that to us?
Yeah, I can certainly tell you the two theories, and I think the jury is still out. So I think most of this started with Bjorn Nolman's work at Vanderbilt, and he actually sort of did a screen of a whole bunch of antiarrhythmics to see which might influence ryanodine receptor gating to deal with the leaky ryanodine receptor problem. And flecainide was very effective. And then they made mice with a humanized ryanodine receptor mutation, and it was very effective in blocking those arrhythmias. And then that moved on to clinical trials in humans. There are other groups, though, who think that the flecainide is actually blocking the membrane sodium channel, and it's through some complicated sodium-calcium exchange that the effect is not primarily on the ryanodine receptor. So I think there's still debate in the field, and I think this debate started probably 5 years ago and is still going on. The bottom line is it could be effective in a subset of patients, but the exact mechanism is still not entirely clear.
So these patients, when you diagnose them, as I said, you typically put them on a treadmill, you start seeing these PVCs, they're catechol-driven entities, and certainly we can, again, lifestyle modifications in terms of avoiding stressful situations, exercise, that kind of a thing. Beta blockers, again, flecainide, as we just discussed. What about ICDs? I mean, the problem with ICDs in this population is, of course, that if you get an ICD shock, you get a sympathetic surge, which can drive more arrhythmias, more shock. So really, ICDs in CPVT patients should be used in concert with other suppressive therapies. ICD should be a backup, but patients should be on beta blockers. Again, sympathetic denervation, which we don't do that often, is something to actually consider in this population. Srini, do you want to talk a little bit about, we talked about ablation in the context of Brugada patients and all this emerging data in terms of substrate. But there have been patients, as you know, that we've ablated who've had either long QT syndrome or CPVT based on PVCs. Do you want to just discuss a little bit about that?
Yeah, no, it's just as you described, unifocal PVCs often triggering these events, and the sources are typically, the sources of these PVCs are typically what's described in patients with idiopathic VF also, Purkinje related, whether it's left Purkinje or right Purkinje system, and rarely outflow tract PVCs can be the triggering PVCs that result in these polymorphic arrhythmias. And so targeting these PVCs can often suppress, at least temporarily, for the arrhythmic episodes.
Amy, before I head away from CPVT, we talked about role of genetic testing in Brugada syndrome, long QT. What about for CPVT? What's the role there? And if you could also summarize at the end how you see the importance of genetic testing in these three in order.
Yeah, so to answer the first question first, again, because the genes have not been as well, I mean, we have the characterization of RYR2 and CASQ1, but the yield on genetic testing is much lower for CPVT than these other channelopathies that we've been talking about, namely long QT, which is the best characterized. So the yield is pretty low. I myself have not seen any CPVT patients come through our cardiovascular genetics program. As far as I'm aware, Barry might have had some on the pediatric side. But these two genes are included on the arrhythmogenic panel or arrhythmia panel that we use. And so when we're looking at postmortem specimens, I think that's an area that it's most likely to come up as an incidental finding on someone who's had a sudden cardiac death. So, we haven't seen it yet, but certainly it wouldn't be surprising on a patient with sudden cardiac death where the yield on genetic testing in general is ranged to be up to 80%. So I think, if a patient has CPVT, it's worth doing the test if you have a proven diagnosis, but I haven't had that myself.
Glenn,
I think the yield is best for long QT syndrome, to answer your second question.
Glenn, any comments in terms of genetic testing? How do you do things differently or the same compared to what you've just heard?
I think what Amy has described is pretty common. I would make a few general comments that genetic testing really should be done with centers that have the appropriate genetic counseling. You're going to send people who are moderate to low probability of actually having one of these diseases. You're going to get sequence variants coming back. Getting back to Mike Ackerman, you're going to get, to sort of this genetic purgatory. You're going to get sequence variants. It's not clear that they're actually associated with the disease. You're not going to be sure what to tell the family about whether this individual has a mutation that's responsible for their CPVT or long QT. And then there's going to be all this cascade screening, and it's not really going to be the etiology. So you want to have an informed either physician or genetic counselor doing all this work so that they understand what they're getting into and you give them good advice. I think that's really key. Otherwise, you're going to be scaring a lot of individuals who really do not have a causative mutation that you've identified.
So I actually, this time, for once, I've left a little bit of time at the end for questions, unlike usual. So we have about 10 minutes. If anybody has any questions, Marty would like you to talk through the mic. Questions, comments? Otherwise, next time I'll go to the very end.
I actually had one quick question.
Yeah.
So with the rise of subcutaneous ICDs,
Good one, yeah.
how does that impact maybe Dr. Love, especially in young children, or how does that impact your thoughts and decision making when it comes to putting an ICD in somebody who, you're now going to maybe have less risk of the leads and, sort of long-term complications?
No, it's a good point. I mean, and actually it goes back to your earlier question about pacing, right? So the one big disadvantage of sub-Q ICDs is the fact that you can't pace with them, at least not yet. Having said that, by the way, we're going to have leadless pacers that can communicate with defibrillators in a clinical trial pretty soon. So the EP community in the country is going to have something new to offer. But, and I think, you know, Barry probably, I'll let you comment, Barry. I mean, the devices are big, and in adults, they're actually great because they hide in the space. Kids don't have much space here. Barry, you want to comment on?
Yeah, I mean, we put them in small children, and the plastic surgeon has helped us put them, underneath the latissimus. But still, they're really big, and you still end up with lead problems. And I mean, we had a lead erode, and it's not great. And the other problem is the programming of these devices is not very robust. So, for instance, in CPVT, I have some patients where I put them in for secondary prevention and set a very, very long detection window. And they come back and they've got non-sustained VT that's just been monitored. They haven't been shocked for it, and they've been fine. But you can't do that so easily with a sub-Q ICD. There's a lot less robustness with how to program it. So I haven't felt like that's really changed the paradigm so much in the young patients. Certainly in the younger adult, maybe has a little bit more value from that standpoint.
Yeah, certainly. I mean, in the adult I don't want to be negative about it. In the adult patients, we actually use it quite frequently. And in fact, when SICD first came out in the US with the approval, even in the clinical trial, the majority of the patients were actually these kind of patients. The younger, not kids, but younger sort of 20, 30-year-old patients where we're worried about leaving a vascular lead for the rest of their life. And we actually use sub-Q ICDs quite aggressively and still do. But Srini, you want to make a comment?
One thing, you have to screen these patients appropriately. A lot of them may be screen failures because of the T-wave oversensing.
That's right.
For patients with Brugada long QT syndrome, these patients just may not be appropriate candidates for sub-Q.
You have to screen them. Yeah. Fadi.
And on a hopeful note from the Basic Science Laboratory regarding pacing in kids, there's a lot of momentum in this field right now with even a clinical trial starting where biopacemakers are being tested. So a group at Cedars-Sinai has figured out a transcription factor that shuts off after birth, and that's responsible for the pacemaker phenotype. And they figured out a way to reawaken that in a group of cells to start, to be able to develop a biopacemaker, and this is ideal for pediatric patients. So there is some movement here as well. Yeah.
Questions? Actually, I have a question because I want to ask about, since you raised the topic, I've been hearing about biopacemakers now for about 10 years, and I'm getting a little impatient. I'm being somewhat facetious, but what are the real blocks right now? Is it the vector? Is it getting stable transcription? What is it?
Right, so the approaches, and Glenn can also elaborate on this. The approaches in the past have been to try to deliver certain genes, to create a phenotype that looks like a pacemaker cell, and to get and it requires basically long-term expression of that, what you're delivering, and to stay on for life. The different approach that's being taken by Eduardo Marband's group is delivering a one-time transcription factor to a certain set of cells, which would convert them, and they would stay converted, creating a true biopacemaker. And time will tell if that approach actually will yield or not. But they are, I think, starting in a clinical trial on this. Yeah.
So Glenn, can you comment on that, or just in the whole general concept of genetic therapy, be it cell therapy or vectors of some kind for arrhythmia syndromes?
I think one of the main issues for cardiac electrophysiology and gene therapy has been that the delivery systems have been relatively inefficient, and the delivery therefore has been heterogeneous. And when we in the EP field think about heterogeneity, that's sort of the kiss of death for arrhythmias, right? So we have heterogeneous action potentials. That's what allows for reentry. And I think we've always been concerned if we deliver a gene and it goes into 10 or 20% of cells, we're going to make things worse rather than better. Cells are well coupled, though, And so there probably is a threshold where it doesn't have to be 100%. Maybe 50% is enough that because it's a syncytium, we can get the effect that we're looking for. So for pacemaking, where we may just need a small area affected to serve kind of as an artificial node, the original approach, and actually this dates way back to Marband's work, was putting in, let's say, a pacemaker channel. So you're taking a regular ventricular cell and you're giving it the minimum requirement to beat spontaneously. The problem with that, it's not really subject to any regulation. So it doesn't have the rest of the machinery to speed up or slow down with stress or with exercise.
Right.
The transcription factor approach, we talked a little bit about this at noon though, is reprogramming the whole cell. So now you're taking a ventricular cell and actually turning it into a pacemaker cell, and it's much more likely that its physiology is going to recapitulate normal physiology. So I think it's a more rational approach.
And how worried are you about bad things that we can't, oncogenic potential and all this other stuff?
Yeah, so I think part and parcel of these developments is sort of CRISPR and gene editing, where we can go in now in a much more surgical way to modify the genome. So I think we're going to get over these technical hurdles in the next couple of years. I mean, we're already moving from large animal trials to repair muscular dystrophy by fixing the dystrophin gene. I think that's going to just spread like wildfire over the next half dozen years.
So maybe we'll end with me asking you to make a prediction. So when will the first patient be treated to receive an artificial pacemaker? Artificial biological pacemaker, let me be clear.
6 years.
6 years, okay, that's pretty good.
That's pretty good.
Okay.
Can I just say, I'm not selling my Medtronic stock just yet.
Very good. Any other questions? Okay, that's a wrap.